Hi, I'm Dr. Mila Brujic, and today we're joined on the OI show by Dr. Kaleb Abbott, where we're going to be talking about the pain game. Welcome, everybody, and thank you for joining us on this episode. Dr. Kaleb Abbott, thank you for joining us on this episode as well, too. For the listeners that may not know you, share with them a little bit about your background, where you practice, what you spend most of your time doing.
Yeah, thanks for having me on the podcast. This is great to be here. So I am an optometrist and assistant professor at the University of Colorado School of Medicine. I practice in our dry eye clinic and our Center for Ocular Inflammation. So I'm mostly seeing complex ocular surface disease cases, a lot of the difficult cases that get referred in from outside providers. So we're kind of a tertiary referral site for all of the state of Colorado, but also surrounding states as well. And with that comes a lot of challenging conditions such as neuropathic ocular pain, but also things like thyroid eye disease and neurotrophic keratitis, ocular cicatricial pemphigoids, graft versus host, just a lot of those kind of messy ocular surface disease cases.
Well, Kaleb, let's take a little bit of a step even back to further. Where did you go to optometry school? When did you graduate optometry school?
I graduated in 2018 from University of Houston, and I did my OD there. Then I also worked on a master's degree in physiological optics too.
Oh, that's great. So, Kaleb, really the thing that we want to talk about today is this kind of perplexing condition that we're starting to become more comfortable with in the profession, but we're still trying to really define, which is this kind of slew of signs and symptoms that we place under this umbrella of neuropathic pain. We sometimes refer to it as neuropathic dry eye. Tell us a little bit more about this condition. Enlighten us on this.
Yeah, well, when I first started practicing in our dry eye clinic, I quickly realized that dry eye is a lot more complex than I thought it was. I started to notice kind of what everybody notices, that dry eye signs don't equal symptoms. And I think when we take a step back and we look at the history of dry eye, we used to think it was just Sjogren's disease. We thought that any condition that attacked the lacrimal glands, decreased lacrimal gland secretions, caused dry eye. And we thought it was really as simple as that. Then we started to understand inflammation and that kind of common denominator there. But still, we couldn't figure out anything that would correlate dry signs and symptoms. So we started to get fancy. We started to look at lid margin disease and meibomian gland dysfunction, tear film stability, ocular rosacea, ocular rosacea in the form of like lid margin telangiectasias and the kind of Demodex blepharitis component and the microbiome. But still, no matter what we did, and no matter what diagnostic test we did, we still couldn't figure out a way to correlate signs and symptoms, even when we did things like MMP9 testing and tear film osmolarity. So I think that kind of taught a lot of practitioners that we need to take a step back and try to understand what's really happening here and what are the role of the corneal nerves and how is that impacting the signs versus the symptoms that our patients are having.
So, Kaleb, this whole concept of neuropathic pain, or what's now starting to be referred to as neuropathic dry eye, it is interesting because these individuals, um, they're the ones that we look at, and they, relatively speaking, look somewhat normal, but they carry a high level of symptomology with them. Are there any type of diagnostic tests where you can say, yeah, so this is the person that has that neuropathic form of dry eye? And if there is, what are those tests that are available?
Well, it's difficult with neuropathic pain in general, and this is not just true of the eyes, but of the body itself. There's not a whole lot of good diagnostic tests. There's one thing that we have at the University of Colorado, which is in vivo confocal microscopy. So we can actually image those corneal nerves 600x, and we can see evidence of microneuromas and problems with that subbasal nerve plexus of the corneal nerves itself. But most people don't have access to that. So we really rely primarily on symptoms that our patients are experiencing. So, kind of like you said, when dry eye symptoms are disproportionately greater than dry eye signs, that is indicative of neuropathic pain. There's also presence of spontaneous burning or different certain characteristics like things like hyperalgesia, where you have an increased response to something that really should be causing a little bit of discomfort, but it causes a lot of discomfort. A good example of that is wind. Wind should bother your eyes a little bit, but not a ton. Then there's things like allodynia. So that's essentially pain that's happening when there shouldn't be pain. So these patients could classically come in and say, oh, light just kills my eyes. And they'll be talking about indoor lights, or they'll be talking about computer lights or things like that. So that's evidence of a neuropathic ocular pain as well, something that's causing pain, but again, shouldn't cause pain. That's evidence of a somatosensory dysfunction. Then there's the lack of response to traditional dry eye therapies that can be indicative of neuropathic pain. The biggest one, though, is coexistence with other chronic pain conditions. So we're talking about things like fibromyalgia or small fiber neuropathies or migraines and things like that. Because I always tell patients that pain typically travels together. You get pain somewhere else in the body, you're also likely to get pain in the eyes as well. So another way to think about this is sometimes the dry eye symptoms that our patients are having may not actually be dry eye at all, but may be evidence of and actually a manifestation of a systemic chronic pain syndrome that's just happening to cause symptoms of dry eye.
So Caleb, we're hearing a lot in the literature now about a proparacaine test for these individuals or for people with dry eye, where you ask patients on a scale from 0 to 10 to rank their discomfort with their eyes, instill proparacaine in the eyes, and then wait about 90 seconds and ask them to grade the discomfort of their eyes, again, on that same 0 to 10 scale, 10 being worst, 0 being the best, to determine whether or not proparacaine does have an influence locally on what the patient's feeling. Do you find value in that test? And if so, are you utilizing that in your clinical practice?
Yeah, there's a couple of different tests that you can do. Proparacaine is probably the easiest one because it's readily available. But to me, this is absolutely essential whenever you have a patient that you suspect may have a neuropathic component to it. And essentially, you're going to put a drop of proparacaine in and you're going to wait 60 or 90 seconds. You're going to see the change that occurs in pain and discomfort, but also light sensitivity if that is a component of their discomfort. And you'll find that if they have a reduction in their pain, like maybe they'll say, it's 60 or 70% better, then that's evidence of a peripheral neuropathic pain, or more so a peripheral neuropathic pain, because you've numbed those corneal nerves, which are located in the peripheral nervous system. And since you've numbed them, they're having less pain. So when patients will tell you that the pain has not decreased at all when you put a numbing drop in the eye, then it's either a non-ocular or it's a central neuropathic pain. And I think it's important for us to understand that you still have to rule out whether or not there's dry eye. And there also can be dry eye and there can be neuropathic pain at the same time. There's no reason that you can't have both, and the dry eye will exacerbate the neuropathic pain. So again, if the pain decreases with proparacaine, then it's either peripheral neuropathic pain, so coming from the corneal nerves, or it's dry eye. And it's your job as the eye doctor to try to figure out which one it is. And then if it doesn't improve at all, then it's either central neuropathic pain or non-ocular.
So is there a different way that you communicate with patients if you find that it's peripheral neuropathic versus central neuropathic pain? And if so, what does that difference sound like between those two subsets of patients?
Well, it's different counseling, but it's also completely different treatment. So if you find that something that even proparacaine, something that completely numbs those corneal nerves, doesn't result in improved symptoms, then you'll honestly be wasting a lot of your time trying to treat something topically. Because if proparacaine can't help it, then it's unlikely that prescription dry eye drops or things like that are going to help it. So you have to figure out exactly where the pain is coming from, peripheral nerves or central nervous system. And then you have to educate your patients as well. I mean, this is a very difficult condition to treat in general. So I always tell patients that we're going to try to get incrementally better. It's going to take time. We're going to try certain things. If that doesn't work, we're going to try other things. But the difficult cases are the ones like you were saying, if it's more central neuropathic, where you can't really do topical treatments to help improve their symptoms. So at that point, you're relying a little bit more on oral medications, maybe like a Lyrica or gabapentin. You're relying maybe on trigeminal nerve blocks with bupivacaine or budesonide, and you're probably going to be trying to co-manage that with a neurologist or a pain specialist as well.
Is there anything that we have that might play a role in this? Meaning, There have been some anecdotal reports around varenicline, nothing that's controlled studies up to this point. And we've even seen some of these patients actually improve with varenicline nasal spray that actually activates the trigeminal nerve. And we think it might be feeding back to that central pathway to somehow modify this signal. Have you seen the same thing? And is there anything else that you're specifically using in your office that can help these patients before you maybe send them for pain counseling and or working with neurology?
Yeah, that's a great point there. This is something that I think a lot of us have been experimenting with for a bit now. So the intranasal varenicline is going to stimulate that trigeminal nerve. And when we use it for dry eye, we're trying to stimulate the nerve to increase or augment the lacrimal gland secretions. But I've found clinically that if you use intranasal varenicline instead of twice a day, maybe 3 or 4 times a day, you can actually kind of overstimulate that nerve. And there's a theory in neurology called gate control theory. And that theory essentially says that if you overstimulate a nerve, you're going to shut down those calcium channels and those sodium channels, and you're actually going to impede the ability for that nerve to fire. So you're essentially trying to overstimulate it as a means to essentially reset that nerve, as to decrease the pain and the misfiring happening along that trigeminal nerve. So that's a great point. That's something that practitioners can definitely try. It seems to work well in trigeminal neuralgia patients specifically, but we have to educate our patients that it is off-label.
Caleb, this was absolutely fantastic. It's clear that you work with these patients a lot, and it's clear that you think about this topic a lot too. You can't imagine how appreciative I am for you being a guest on the show today. Thank you so much.
Yes, thank you.
And thank you all for joining us on this episode of the OI Show, where we talked about the pain game.